Hello, this is Dr. Jason Lee. In this last lecture, we'll be talking about how to treat patients with humoral immune deficiencies. Now, as you noticed from the SCID lectures by Dr. Kim, there are other combined cellular humoral immune deficiencies that also warrant immunoglobulin replacement therapy as well. In any event, the treatment for resultant defects in humoral immunity is essentially to give passive immunity by giving patients external source of donor immunoglobulins. Systematic reviews of literature assessing the effectiveness of IVIG among patients with PID and SID have concluded that immunoglobulin replacement is an effective means for decreasing the incidence of major infections. Commercial preps of immunoglobulin replacement therapy is produced from pooled human plasma and consists of mostly IgG. And if we look at the distribution of this, the subclasses are equally represented as they would be in a normal individual. Immunoglobulin infusions are not designed to replace other immunoglobulin classes, so your IgA and M levels will not really budge, even though there's a tiny bit of IgA in most preparations. So do not be surprised if only the IgG goes up. This is because you're only replacing the IgG. There are different guidelines on when to treat immunoglobulin deficiencies. Asymptomatic hypogammaglobulinemia is not generally a reason for treatment according to the 2007 Canadian Guidelines for Use of IVIG in Hematologic and Neurologic Conditions by Hume et al. And 2012 Guidelines on the Diagnosis, Investigation, and Management of CLL by the British Committee for Standards in Hematology. And we recently have just had a paper accepted on the Canadian perspective of immunoglobulin immunotherapy to reduce infectious complications in CLL by myself and several others. Let's talk about IVIG. This is administered in a hospital site with the process taking up to 2 to 4 hours. This depends on the rate of infusion and the amount of IgG the patient's actually getting. The dosage and frequency vary depending on the patient's weight and immunoglobulin level. Giving someone IVIG gives to an immediate rise of serum immunoglobulin concentration to very high levels, followed by a fall over the next 3 to 4 weeks. Since immunoglobulin is directly going into the vein, relatively large amounts can be delivered at a time. People can generally get by with one dose per month or every 3 weeks. However, different patients catabolize immunoglobulin at different rates, and this may be individually tailored. Despite the well-established safety profile, when you compare this to SCIG, there is a higher chance of adverse events, especially those that are related to high peaks of IgG. So this includes things that are mild adverse events such as fevers, muscle ache, headaches, to more severe reactions such as hemolysis, hypotension, trolley. IVIG also requires a lot of economic resources compared to SCIG, as seen by multiple American and European reviews, such as Berger et al. In 2004, Garduf et al. In 1995, and Radinsky and Bonagura in 2003. So the other treatment that is relatively newer is subcutaneous, and it involves slowly infusing the immunoglobulin preparation directly onto the skin in the sub-Q space. It results in IgG being initially distributed in the local subcutaneous tissue, followed by a slow diffusion into the vasculature and extracellular space. The main advantage of this is that patients can do this at home on a weekly basis with either a special pump or a simple syringe system. And for patients with difficult IV access, this circumvents that altogether. It's generally well tolerated, and it's been shown to have decreased frequency of systemic and clinically relevant adverse events compared with IVIG. The frequent dosing also results in a more stable, higher trough IgG serum that can remain almost stable between consecutive sessions as compared to serum levels in IVIG. It's been demonstrated in clinical trials to show that majority of patients prefer the convenience and quality of life improvement.